Welcome to the 2018 PEMS Protocol Update. Administrative changes this year is the termination of resuscitative efforts in the field and the removal of the STEMI thrombolytic checklist. The changes to the death and criteria for withholding resuscitation is to allow the EMT and EMTA to terminate in the field. As a reminder, all levels of EMS must contact medical control. The reason is that the MAC is allowing providers to function to the full level of their certification following AHA guidelines. Providers are reminded to provide full care according to their level of certification once resuscitation efforts have been initiated. The thrombolytic checklist has been removed because hospital representatives have found it was not very useful. The STEMI work group has also stated that PCI is currently the standard care for STEMI. The VHAA has added specificity to diversion announcements. For example, CT down will mean the CT is not working. Also, a closed option has been added indicating not to bring a patient to the hospital. This is so there will be improved communication with providers. Providers should fill out an MIR if a doctor diverts a specific patient to another hospital. This is also referred to as a soft divert. These forms are found on the PEMS website. A completed MIR helps to improve the standard of care. Several changes have been made to the adult protocols for 2018. A significant change to the behavioral patient restraint protocol is the addition of B52, allowing paramedics to administer medications for chemical restraint in a single dose. As you'll see in this brief video, if a psychotic or behavioral patient is suspected, combine 5 milligrams of Halidol, 2 milligrams of Ativan, and 50 milligrams of Benadryl into a single syringe and administer to a large IM site, such as the thigh, hip, or buttocks. In the case of a psychotic or behavioral patient, the use of B52 has been approved by the PEMS protocols. Grab your syringe and blunt fill needle and draw up each of your drugs. 5 milligrams of Halidol, 2 milligrams of Ativan, and 50 milligrams of Benadryl. Each should come in a 1 milliliter vial. Once your medications are prepped, locate the appropriate site in either the thigh, the hip, or the buttocks. Administer medications IM. Make sure to properly dispose of all sharps. A new hemorrhage control protocol has been added to address using devices such as a hemostatic dressing and tourniquet for uncontrolled or profuse bleeding. This is to give PEMS providers an algorithm for treating such patients. Emergency room physicians have noticed that patients, particularly elderly patients, have been receiving too much fentanyl as an initial dose. Therefore, the initial dose has been reduced to 25 micrograms over 2 minutes. In addition, providers are reminded to proactively consider patient responses before administering increased doses. Non-pharmacological procedures have been added to the pain control protocol. For example, reassurance, distraction, imagery, music, and more. To align the chest pain protocol with the new pain control protocol, the initial dose of fentanyl has been reduced to 25 micrograms over 2 minutes. A direct correlation has been found between capnography and lactate levels. Therefore, capnography has been added to the sepsis protocol. A reading below 26 millimeters of mercury can indicate hypoperfusion. There has been one change made to the pharmacology protocol for 2018. In response to a potential shortage of D50, the option of D10 has been added to the protocol. There have been 3 changes made to the pediatric protocol for 2018. To align PEMS with the Virginia OEMS scope of practice, nebulized epi for croup has been removed for the AEMT. In the pediatric altered mental status update for 2018, the use of nebulized Narcan has been approved for all EMS providers. This is done by using the nebulizers provided, adding 1 saline bullet, and the entire dose of your Narcan. Due to the nature of the patient, your nebulizer will need to be used with a mask. Once your setup is complete, connect to your oxygen and place on the patient's face. You will then titrate to effect. The third change made to the pediatric protocols is to align with a consensus definition of hypoglycemia. This states that pediatric hypoglycemic patients other than newborn and neonates have changed from less than 40 milligrams per deciliter to less than 60 milligrams per deciliter. This is not a change but a reminder of the importance of RACE for a pre-hospital assessment in stroke. Strokes can vary in severity depending on the size of the vessel affected. Therefore, proper pre-hospital assessment is essential. A large vessel occlusion is a kind of ischemic stroke that affects any of the proximal blood vessels of the brain, including the internal carotid arteries, the middle cerebral arteries, the basilar artery, and the anterior cerebral artery. Proper identification of a large vessel occlusion is important because they have been associated with a 5-fold increase in death and a 3-fold decrease in a good outcome. Rapid identification of severe stroke symptoms using RACE by EMS and transport to a comprehensive stroke center have had significant impact on patient outcomes. Screening tests prior to RACE help to identify that a stroke had occurred, but not the severity, nor the probability that it is a large vessel occlusion. Even when unable to transport to a comprehensive stroke center, a RACE score must still be given to the receiving facility. Here's an example of the RACE scale that you also have available in your PEMS protocols. When calculating RACE, the highest score possible is 9, being either aphasia or agnosia. Determining and reporting the RACE score for a suspected stroke patient is the current standard in PEMS protocols and best practice for EMS providers. Medication training boxes are now available throughout PEMS and labeled specifically not for patient use. Contact the PEMS office for more information or to purchase. All protocols are endorsed by the Regional Medical Advisory Committee. If you are receiving any negative feedback from ED staff, please consider notifying your supervisor and documenting in a medical incident review form available on the PEMS website. Working together is the only way we make the system better. Thank you for your help.